autoimmune diseases on the eye. Okay. So let's begin. So ocular inflammation is seen in a number of autoimmune diseases, and inflammation can in fact affect any part of the eye, starting from the anterior segment, the eyelids, cornea, to the posterior segment, retina, sclera, optic nerve. And in some conditions, uveitis or scleritis may even precede systemic presentation. So let's start off with a few case presentations to get us generate some interest, I hope. So this is the photograph, anterior segment photograph of a 52-year-old female with sore, gritty eyes following installation of fluorescein dye. And she's known to have seropositive rheumatoid arthritis. Let me see who has joined the lecture. I'll start off with Miss Gordon, Adenike Gordon. Miss Gordon, are you there?
Yes, Doc.
Hello?
Yes, Doc. Can you hear me?
I'm not hearing you.
I'm here, Doc. I'm trying to. Can you hear me? Hello?
Okay, let's go to the next person. It's Wiseman. Amanda
Can
Wiseman.
she hear me?
Good morning, Doc.
Miss Wiseman.
Good morning. Can you hear me?
Hello?
Hello?
Is everybody's microphones are up? People are responding, but I'm not
Yes, Doc.
hearing you.
I'm not sure if you're hearing
I'm not quite sure why I'm not hearing. I'm not hearing anybody. Let me see. What are the responses? So why is it that I'm not hearing? Very strange.
Doc, this is
let me
Adenike.
close and go back in because I'm not hearing anybody.
Okay.
Good morning. Is anyone hearing me?
Yes, Doc. Can you hear us?
Okay, I'm hearing. Who's speaking now? Is this Miss Gordon?
Adenike Gordon. Yes, Doc.
All righty. Okay, so this is an eye of a 52-year-old female who. Let's go back now. Right, 52-year-old female. Four gritty eyes. Can you see you're seeing the slide, Miss Gordon?
Yes, Doc. About with the fluorescein dye.
Right. So why has the fluorescein dye been used? Why would we use fluorescein dye? Why do you think we have used fluorescein dye?
Is it to like highlight the inflammation?
Well, okay, I'm going to put on my pointer. So we have instilled fluorescein dye. What do you think is this? Is if I'm going to tell you, so that's the fluorescein pooling there at the bottom with the tear film. But notice, you see my pointer. What do you think is happening here?
You have corneal abrasion and the fluorescein dye has affinity for that?
I'm not. What?
Right. So it's not a full abrasion. We would actually call this punctate epithelial staining. So you see it's like little pinpoint areas of staining. Okay. And happens in
What did you say it would be called though?
punctate epithelial erosions or punctate staining. We call it abrasion if all the little punctate stains then coalesced into one large abrasion. Okay, but this is what we call punctate staining or punctate epitheliopathy. And this is found in patients with very dry eyes. Anybody knows what the normal tear breakup time is? You probably don't know that yet. No? What are the systemic associations in secondary Sjogren's syndrome? Anybody have any idea about Sjogren's syndrome? Sjogren's syndrome is?
That is when it is second. That's when you have dry eyes, dry mouth.
Correct. So it's an inflammatory condition which affects not only the lacrimal gland, but the parotid glands, and you get a dry eye and a dry mouth. Okay, so let's move on. So this patient has a dry eye, okay? So the precorneal tear film, I don't know how much anatomy you know about the eye, but the tear film has 3 layers. You have your lipid layer, an aqueous layer, and then you have your mucin layer, right? The outer lipid layer is secreted by the meibomian glands and the glands of Zeiss and retards the evaporation of the aqueous layer and basically lubricates the eyelids as they pass over the surface of the globe. The middle aqueous layer is secreted by the lacrimal glands. And then you have an inner mucin layer, which is generally secreted by the conjunctival goblet cells. And in a dry eye syndrome, which we also call keratoconjunctivitis sicca, refers to a dry eye primarily resulting from aqueous tear deficiency, which is the middle layer of the tear film secreted by the lacrimal glands. It is actually the most common ocular manifestation of rheumatoid arthritis, with a reported prevalence of 15 to 25%, but may also be seen in other autoimmune diseases. I commonly see it in patients with lupus and other autoimmune diseases which are not as common. You can see it in psoriatic arthritis, juvenile rheumatoid arthritis, Sjogren's syndrome, okay? But it's a common presentation in patients with rheumatoid and SLE in the Jamaican setting. And it's caused by destructive inflammation of the lacrimal gland by TMB lymphocytes, leading to decreased aqueous tear production. Of course, the symptoms, 90% of the patients are female, and the symptoms are, as you would expect, discomfort, burning, stinging, grittiness. You can even get blurring of your vision because, as you know, the tear film is the first refractive surface of the eye. So if you have a disruption in your tear film, you will get blurred vision. You can also get very mild photophobia. I'm sure some of you might have experienced this when you've spent too long on your devices and your eyes become dry. You can get transient blurring of your vision, a little bit of light sensitiveness, and red eyes. Okay. The symptoms of keratoconjunctivitis sicca are frequently exacerbated on exposure to conditions associated with increased tear evaporation. Fans, or when the blink reflex is reduced, such as prolonged reading and increased screen time. So what are the signs of a dry eye syndrome? You get conjunctival injection and tear film abnormalities. Normally there is a tear meniscus, which is about 1 millimeter in height, but in the dry eye, the marginal meniscus is frequently thin or absent. You have corneal abnormalities. You get, as I showed you in that first slide, you get punctate epithelial erosions that stain with fluorescein. And in very dry eyes, you also get mucous filaments, and we call that a filamentary keratopathy. And in rare complications, in a severely dry eye, you may see corneal neovascularization, perforation, and even infections, bacterial keratitis. And there are special tests that we do for the dry eye syndrome. Okay, you have here what we call the breakup time, where we instill fluorescein dye into the inferior fornix. The patient is asked to blink and then stop, and then you measure the interval between the last blink and the appearance of dry spots on the cornea. Usually takes about 10 seconds before you see dry spots appearing on the cornea, right? So a breakup time of less than 10 seconds is considered abnormal. Other tests that we do for dry eyes are rose Bengal, which is another dye, and the Shermer's test, right? So this is just illustrating again a dry eye. This patient has a mild dry eye. You can see a few little punctate stains here, as opposed to somebody with severe dry eyes, where you have punctate staining involving almost all of the cornea, and that's a severely dry eye. Another dye that we use in dry eyes is a dye called Rose Bengal. We don't use it much because it's actually very irritating to the eye, and the patients don't tolerate it very well, but it stains particularly for devitalized epithelial cells and mucus. So you can see all the mucus filaments here, which stain red, which you get a filamentary keratopathy in severe dry eyes, usually seen with patients with rheumatoid arthritis. And of course, I'm sure you've all heard of the Shermer's test, where you measure the amount of filter paper that becomes wet. So you insert this filter paper in the inferior fornix, and you time for 5 minutes, and you measure how much of the filter paper becomes wet. After 5 minutes, at least 15 millimeters of the filter paper should be wet. Less than 5 millimeters would indicate impaired tear secretion, and 5 to 10 millimeters of wetting is considered borderline. Okay, so that's a Shermer's test. So that's 3 tests that we do to assess a dry eye. And as I said, usually it's patients with rheumatoid arthritis and SLE, but seen in practically any autoimmune disease where you have the lacrimal gland being attacked, you can end up with a dry eye, and it's actually pretty common. All right, and as I mentioned before, you can get what we call filamentary keratopathy. In severe dry eyes, you get mucous filaments. Okay, you can see that there. And the next slide, this is a severe case eye where the patient ends up with corneal ulceration and neovascularization. So new vessels and scarring of the cornea in severe dry eyes. Okay, what's the treatment? How do we manage patients, our rheumatoid patients and our SLE patients? Well, the main goal is to preserve or replenish the tear film. Okay, Patient education, very important. Simple measures. Avoid drying environments. Room. Okay, so don't sit under vents, AC vents with the AC blowing in your face. Don't sit in front of fans with the fan blowing directly into your face. Use room humidifiers. Decrease your screen time for all you students, even when you don't have rheumatoid or any underlying systemic condition. Dry eyes is a very, very significant problem with all this, online teaching. So you try to decrease your screen time, take breaks. Very important to blink whilst reading or using a computer to keep your cornea moist. So just some simple measures that can be done. Then of course, topical treatment. We use artificial tear substitutes, all of which are available over the counter, that patients don't even need a prescription. You might have heard of Refresh Tears, Sustain Ultra. There are many different preparations available over the counter. Now, in patients who are really having very severe dry eyes, right, because particularly, as I said, patients with rheumatoid arthritis or SLE, then we may have to resort to what we call punctal occlusion. And we occlude the punctal. It can be either temporary, where we insert a collagen or silicone plugs, usually into the inferior punctum, or in very, very severe dry eyes, we can do permanent occlusion, usually cauterizing the canaliculi. And just to mention Sjogren's syndrome, where you have autoimmune inflammation and the destruction of the lacrimal and salivary glands. And it's primary when it exists in isolation, but it's classified as being secondary when associated with other diseases such as rheumatoid arthritis, SLE, psoriatic arthritis, JRA, okay, Hashimoto's disease, Hashimoto's thyroiditis, and usually presents in adult life with a dry, gritty eye and dryness of the mouth. And you can read about all the different clinical manifestations of Sjogren's disease. Okay, so that's basically about that. That is one of the main presenting symptoms or conditions of patients with autoimmune disease. They frequently present with a dry eye, and it's due to destruction of the lacrimal gland. And the lacrimal gland, as I said, produces the aqueous layer of the tear film. So just a few MCQs. True or false? Is keratoconjunctivitis sicca more common in warm weather? Is that true or false? Anybody? Is usually due to excessive drainage of tears. True or false? Okay, nobody's answering. So I'm going to leave this section and go to the next one. Okay, false, very good. Should always be treated with local steroids. Is that true or false?
False.
False, right. We try not to treat with local steroids. Lubricate, lubricate, lubricate. Should raise the suspicion of systemic disease.
True.
True. Is it exacerbated by prolonged reading?
True.
True.
Exacerbated by activities that reduce the frequency of the blink reflex?
True.
True.
And what activities reduce your blink reflex? I just mentioned the two main things.
Computer screens. Staring at
Yeah, staring at a computer screen is one of them, which is why all of them get dry eyes, and prolonged reading also. Correct. Prolonged reading and prolonged screen time. So dry eye is can be detected by Sjogren's syndrome or confirmed by Sjogren's test, sorry. Is that true? There's no such thing as Sjogren's test. Dry eye is associated with sarcoidosis. What do you think?
True.
It is true, because sarcoidosis can also affect the lacrimal gland. So yes, the anterior layer of the tear film contains mucin. Is that true? What's the anterior layer of the tear film?
Lipid.
Lipid, right, so that's false.
False.
A meibomian gland hyposecretion causes filamentary keratopathy. No, it's lacrimal gland hyposecretion, okay? Remember, no, your meibomian glands secrete the lipid layer, and filamentary keratopathy is a feature of the aqueous layer deficiency, not the lipid layer deficiency. Is dry eye a cause of epiphora? Can dry eyes cause a watery eye? Anybody?
False.
It is actually true.
True.
Right? So what happens? Remember, you have two different types of tear production. You have your basal, okay? And then you can have tear, if you have an irritated eye, then the eye can water. So it sounds funny. We actually call it paradoxical tearing, okay? So initially your eye becomes dry. I'm sure you'll notice this. When you've had a long time at the computer, the eye initially starts to feel a little bit of, gritty, a little bit uncomfortable, and then it starts to water. So you can get what we call paradoxical tearing. So dry eye is a cause of epiphora, okay? Does everybody understand that? So you have two types of tear production. You have a basal secretion and reflex secretion, okay? All right, let's move on to something else. So that was keratoconjunctivitis sicca, and it's a common presentation in rheumatoid arthritis and SLE, okay? So this is a 45-year-old female presenting with blurred vision, ocular discomfort. Anybody would like to describe what they're seeing? Ms. Gordon, would you like to describe what you're seeing here?
Pardon me, Doc.
Okay, I'm probably picking on you. Let me try somebody else.
Okay, Doc, no problem.
Ashley Scott. Ms. Scott, would you like to describe what you're seeing? No response. Next person, Carlos Andrew. Andrew Carlos. Carlos Andrew.
I got.
Hi. Would you like to describe this photograph?
Sure. I seen a red or inflamed sclera. The iris looks distorted. The pupil looks cloudy. I don't know, but
Okay, all right, so let me help you out. So, right, you said it's a red eye. Okay, so there's some conjunctival injection, correct?
okay.
So this blue part is your cornea, right?
Mm-hmm.
And there is, you can see a demarcation line. Can you see that?
Yes.
Where my pointer is showing?
Yeah.
What do you think is happening peripheral to that demarcation line? This is a cornea here you're looking at. What do you think is happening here in this area?
Swelling?
What do you think is ulceration?
Ulceration.
It's not quite ulceration yet, but there is what we call peripheral corneal thinning.
Okay.
So with this demarcation line, peripheral to that, the cornea here is very thin. And somebody mentioned ulceration. What do you think is this dark tissue coming through? at the limbus. Right, so that's prolapsed uveal tissue. So this cornea has perforated, okay? So this patient has peripheral corneal thinning and ulceration with perforation and prolapse of uveal tissue, okay? And does anybody have any clue what this is called? And what systemic autoimmune disorders is associated with peripheral corneal thinning and ulceration? No. All right. So this is known as peripheral ulcerative keratitis. It may actually precede or follow the onset of systemic disease. If it's severe, in severe cases, it can lead to ulceration, thinning and ulceration. Rheumatoid arthritis is the commonest systemic autoimmune association, followed by Wegener's, polyarteritis nodosa, inflammatory bowel disease, SLE. SLE is actually a rare association. It's more associated with rheumatoid and Wegener's, okay? And what are the signs? You see a crescentic ulceration with thinning, and that ulceration spreads circumferentially. Corneal perforation may occur, as occurred in that last photograph I showed you. How do we manage patients with peripheral, how do we manage these rheumatoid patients with peripheral ulcerative keratitis? Mainly these patients, now this is a very serious disease because, as you can well imagine, corneal ulceration and perforation will lead to loss of sight. And we have actually had patients who have had to remove the eye, eviscerate the eye in very, very severe disease. So this is a very, very serious condition, can be very serious. And the treatment is mainly systemic immunosuppression. And we usually have to manage these patients in collaboration with their rheumatologist. We also give them topical steroids, but that has to be definitely managed by an ophthalmologist because it's a two-edged sword. We need the steroids to dampen the inflammation, but as you know, steroids can also worsen thinning of the cornea. So we use steroids very sparingly. And in addition, these patients, say with rheumatoid arthritis, also have dry eye syndrome. So we also use topical lubricants. But the mainstay of treatment for peripheral ulcerative keratitis is systemic immunosuppression. Okay, and I'll just show you some more photographs. Yes, Mr. Ramprasad?
Hi, doc. So, is there no indication for like, is there no effective use of like other anti-inflammatory uses like monoclonal antibodies and stuff like that won't be effective in this disease?
I've never really heard of it being used, but because no, it's not very effective. As I said, systemic immunosuppression is what we usually use. Cyclophosphamide, methotrexate, just like what you use when you're treating rheumatoid arthritis patients, you know, who are not responding to steroids or to hydroxychloroquine.
Okay.
Right.
Okay, thank you.
You're welcome. So the patient, this, as you can see in this photograph, you see my pointer. So you get this crescentic peripheral ulceration, and it spreads circumferentially. And then you have a very early lesion here, where you can see there's pooling of the fluorescein dye. Okay. And in very severe cases, you can see this patient, you end up with healing, but with this is a peripheral thin cornea, and then you get neovascularization and scarring of the involved periphery. Okay, so that's peripheral ulcerative keratitis. Anybody else has any questions about PUK? We see it we do see it, we actually do see it. We don't see it very frequently, but we do see it in the eye clinic. We probably get a couple cases every year, patients who present with PUK, and quite sight-threatening peripheral thinning, and we've had a few perforations. For the perforation, sometimes what we have to do is use what we call a scleral graft, scleral autografts, to close the perforation to try and preserve the eye and save the eye. So it's not an uncommon situation, disease. Okay. So now, move on, Mr. Rampersad. We have a 25-year-old female presenting with a history of a foreign body sensation and watering in her left eye, right? 25-year-old, just a bit of foreign body sensation and watering. She has no significant past medical history. Her visual acuity is normal, 20/20 in each eye. Right? Would you like to describe the photograph?
I'll try, I guess. So I see injection on the sclera on the temporal region.
Yes. Is it generalized injection?
No, it's localized to the temporal region.
Right. So this is sectoral kind of injection, right? Looks like conjunctival injection. What is the most likely diagnosis? Now think about the history. Female, but she has no significance. She's not known to have any autoimmune diseases, rheumatoid arthritis or anything, lupus. Just a little bit of watering, foreign body sensation, vision normal. What is the most likely diagnosis? Is it a nodular scleritis? Is it an episcleritis? Is this an iritis? Is it a bacterial keratitis?
I'm not sure, but I would either think it's either A or B.
Okay. You think it's either A or B. All right. Anybody else has any thoughts? What it could possibly be? Nobody else has any thoughts on the matter? Yeah, it's a episcleritis, right, Miss Wiseman? Very good. Let's go to the next slide. So what you need to know a little bit, it will help, you really don't need, but it will help to know a little bit of the different layers of the sclera, okay? You have the episclera, which is the vascularized layer of connective tissue, right? The sclera proper is actually an avascular structure. And then you have the innermost layer, where you have the collagen fibers that intersect with your uveal tract. And episcleritis is an inflammatory disorder involving the episcleral tissue that lies just superficial to the sclera proper. Seen more frequently in young to middle-aged women, involves one eye to most of the time, usually idiopathic. However, a third of the cases may be associated with systemic autoimmune diseases such as rheumatoid arthritis, SLE, inflammatory bowel disease. Episcleritis is usually a benign, self-limiting condition and frequently recurrent. Okay, so the history I gave you before of this person was of a young female, no known systemic disorders, all right, with a little bit of discomfort. So it tends to be benign and self-limiting. Clinical features, you have two types, simple or nodular, and the simple episcleritis may be diffuse or sectoral, and the simple episcleritis accounts for 75% of all cases. And it presents with a little bit of redness, discomfort, mild discomfort, okay? It may be nodular, and in the cases when it's nodular, there's a well-circumscribed, often solitary subconjunctival lesion, okay? And how do we treat these patients? Remember now it's usually self-limiting. So basically, for the vast majority, all we give them is artificial tears. And however, if they're having discomfort and it's not resolving, then we can administer topical steroids. And in patients also who have discomfort, we sometimes give them oral NSAIDs, right? So it depends on the level of their discomfort. But the vast majority tends to be self-limiting and not requiring any steroid treatment. Right, so you have, this is, the first photograph I showed you was of a sectoral episcleritis. This is now a diffuse episcleritis. And I don't know if you can appreciate the nodule here. There's a little raised area, and that would be considered to be a nodular episcleritis. Okay, so nodular and diffuse. Okay, so next we go to the next patient, Mr. Ramprasad. So this is a 42-year-old female, so a slightly older person. Now this patient not complaining of just mild discomfort. This patient is now complaining of a very painful red eye, a pain that spreads to her brow. The pain is sometimes so severe that it wakes her up in the morning, and the pain was not relieved by painkillers. Okay, so this is a completely different case scenario, completely different history. So the patient has a red eye, but it's a painful red eye, but it's severe pain, which radiates, which wakes her up in the morning, which is not relieved by your standard over-the-counter painkillers. What is the most likely diagnosis? Is it anterior scleritis? Is it an episcleritis? Is it an iritis? Is it a conjunctivitis?
Is her conjunctiva inflamed?
Yeah, the conjunctiva is inflamed, but you can also see there's almost this area here.
I would go and I
Mm-hmm.
I would probably say it's either an anterior scleritis.
Mm-hmm. Okay, so that is a diagnosis. So because how do patients with an iritis present? By a process of elimination. What is the main symptom of a patient with an iritis?
I'm not sure. But you would see inflammation along the iris, so you'd probably see edema. But I wouldn't exactly seeing.
Anybody know? Have you had your uveitis? Have you had your uveitis lecture yet?
No, we didn't have it yet.
Uveitis lecture? I thought you had it.
No, it's rescheduled for some time.
Oh, it was rescheduled. Okay. Yeah. Right. So patients with iritis, yes, they have a painful eye, but this usually their main symptom is photophobia. So they'll come to you and tell you, oh my, I have a very painful eye and I can't bear any kind of light. So photophobia is usually the main symptom of patients with iritis. Okay, and they get a slightly different kind of inflammation. It's what we call a circumcorneal or ciliary injection. So it tends to look a little different from a scleritis, but the two can be confused, right? But most patients with an iritis are not going to complain of a pain that spreads to their brow or wakes them up at night. Okay, so it's a slightly different. The scleritis is usually more severe. Okay, and radiates. Conjunctivitis is not really painful. You get a little mild discomfort. And remember, we just discussed episcleritis. It's not really painful either. It's just a little bit of discomfort. Okay? So the most likely diagnosis is an anterior scleritis. Any questions so far? So let's talk about, okay, scleritis. Yes, Melanie?
No, I was saying no, doc.
Okay.
Just
So
to, excuse me,
scleritis.
doc.
Mm-hmm.
I was asking, could you go over what you were explaining again between the iritis and the anterior scleritis, between the,
Okay. So, no, it's just basically just from a history. Remember, my first lecture was history. History will tell you almost everything before you even examine the eye. So we looked at a patient with an episcleritis. So all of these patients present with red eyes, okay? So when you're faced with a patient with a red eye and you're trying to determine what could this red eye be due to. So one of the important things to find out is the nature of the pain. If the patient comes into you with a painful red eye, you're trying to decide, is this a conjunctivitis? So you think of all the different things that could give you a red eye. So is this a conjunctivitis? Is this an iritis? Is this an episcleritis? Is this a scleritis? Conjunctivitis and episcleritis usually give you discomfort, usually very mild discomfort. Very rarely do patients come severe pain. Iritis, you do get a painful red eye with iritis, but they usually, the most common presenting symptom is pain which is exacerbated by light, photophobia. So most patients with iritis complain of photophobia. They cannot bear any form of light. Whether it be, overlights or oncoming headlights at night or sunlight, very, very sensitive to light. So light sensitivity is one of the main distinguishing features that questions that you can ask about. All of them can be associated with a little bit of photophobia. But generally speaking, if a patient's main complaint is that they can't stand light, then you have to start thinking iritis, okay? And anterior scleritis, now they come with a painful red eye also, but quite often they'll describe it as a boring ache that radiates to the brow, okay? And also severe that it wakes them up at night. And if they take, it's not relieved by Panadol or Advil or any of your regular painkillers. So a history is very important. All right, Ms. Gordon, does that answer your question?
yes, doc, thank you.
Okay. So scleritis, all right, classification mainly two types, anterior and posterior. Anterior, we have three different types that we describe. We have what we call the non-necrotizing, which is the most common. Then you have necrotizing with inflammation and necrotizing without inflammation, which is also called scleromalacia perforans. And then if you have inflammation posteriorly, we can get what's known as posterior scleritis. Rheumatoid arthritis here again is the autoimmune diseases most commonly implicated in scleritis and accounts for 18 up to 30%, up to a third of cases is secondary to scleritis, secondary rheumatoid arthritis. It's also associated with other autoimmune diseases, your usual SLE, polyarteritis nodosa, Wegener's granulomatosis, okay? Scleritis is seen in up to 6% of patients, of rheumatoid patients, and seen in approximately 1% of patients with SLE. right? But most patients who present with scleritis, you have to investigate them and rule out rheumatoid arthritis. Clinical features, as I mentioned, they present with a painful red eye. Usually it's an insidious, persistent, moderate to severe, and a penetrating or boring ocular pain. Frequently, they describe it as being radiating to the forehead, temple, or jaw. It interferes with sleep and responds poorly to oral analgesia. Signs: you get vascular congestion and dilatation associated with edema. Redness may be generalized or may be localized, as you see in episcleritis, right? Localized to one quadrant. It may also be nodular. You may see single or multiple nodules. And when you have the necrotizing type, you get scleral edema and necrosis. So I'm going to show you a few cases. So this is the necrotizing scleritis, and this entire area here is necrotizing tissue. Okay, it's a very aggressive form of scleritis, maybe bilateral in 60% of patients, and you have isolated areas of scleral edema, and this looks like scleral necrosis, and you can see an area of edema necrosis here with generalized inflammation. Okay, and it can result in severe visual morbidity, even with loss of the eye. So this necrosed area can perforate. These are also other forms of scleritis. You can see, I don't know if you can imagine that there's a nodule here, but this is a non-necrotizing type. I'm not seeing any evidence of scleral necrosis. However, in this area, there seems to be a bit of early necrosis here. So you have a non-necrotizing and a necrotizing scleritis, anterior scleritis. Okay, and let me see if there's anybody who would like to tackle this one. Somebody who hasn't spoken all day. Let me see. Daniel Drakes, is Miss Drakes here?
Yes, Doc, I'm here.
Okay, good morning.
Good morning.
Would you like to describe what you're seeing?
I'm seeing it looks like mucopurulent discharge in the corner by the lacrimal glands, as
Okay,
well as there's some areas of discoloration and nodules on the sclera.
right. So what do you think is happening here? You call it discoloration, but it's actually steroid thinning. So what do you
Oh,
think in these areas?
it's
Why?
probably the precursor to necrosis, maybe.
Well, no, there's necrosis going on, but there's no obvious inflammation. So it's what we call a necrotizing scleritis, but without inflammation. Okay, so in this type, it's called scleromalacia perforans. Okay, so what you're seeing here, Ms. Drake, is actually areas of uveal tissue. But because the sclera is so thin, you're seeing the underlying uveal tissue.
Yeah.
Right here. Right. So that's underlying uveal tissue that you're seeing there. So we call that scleromalacia perforans.
Okay.
Necrotizing scleritis without inflammation. So you don't get this horrible looking necrotic looking area. Okay? So this is necrosis with inflammation. And in this other case, there is inflammation, but you what you're having is gradual thinning of the cornea, and then you're seeing the underlying uveal tissue. Okay? So this kind is a specific type of necrotizing scleritis without inflammation. Typically affects elderly women with long-standing seropositive rheumatoid arthritis. It may be asymptomatic, or you just get a little bit of non-specific irritation and dry eyes. And what you have is very slow progression of scleral thinning and exposure of the underlying uveal tissue. Okay? Treatment is frequently ineffective, unfortunately. All right, and I'm just showing you some more cases of this. So you can have really severe thinning. Okay, so it starts off in the early, so that's early. And then now you have in very late stages, literally the uveal tissue is bulging through. All right, and this is basically perforated, and this patient will lose the eye. We'll try and save it. We can get some scleral grafts to try and cover it, but it's often ineffective because the area is just too large. Okay, so that's a very severe case of scleromalacia perforans. So let's move on to the posterior scleritis now. Serious, potentially blinding condition, often misdiagnosed and treated late. Thankfully, it's pretty rare. 30% of patients have an associated autoimmune systemic disease. Yet again, rheumatoid arthritis is the most common systemic association. Presents with discomfort or pain and tenderness on palpation, but the pain does not correlate to the severity of orbital inflammation. Photophobia is not a dominant feature. And what do we notice with patients with posterior scleritis? They have mild proptosis. They have choroidal folds. They may have diswelling, macular edema, and an exudative retinal detachment. And in 80% and usually in up to 80% of cases, there is an associated anterior scleritis. So most patients present with both anterior and posterior. And we do B-scan ultrasounds, which shows increased scleral thickness, choroidal folds, and a retinal detachment. It can show that if they have an exudative RD. About 85% of cases develop visual impairment from macular edema. So that's the main reason why they may have loss of vision. They develop macular edema from the inflammation of the posterior sclera. And treatment here again is immunosuppression. Topical steroids, topical periocular or systemic steroids. So we usually start off with steroids or NSAIDs, and if that fails, then we go to systemic immunosuppression, such as your cytotoxic agents, cyclophosphamide, azathioprine, methotrexate. And this is a patient with a posterior scleritis. As you can see, you have edema, and you have a blurred disc margin, so you have disc swelling. Okay, and sometimes this is difficult, and there again, you come back to history. This patient has posterior scleritis, but it could almost look like an arterial occlusion, and which is why I showed you this photograph. But there in this photograph, you can actually see an embolus. Okay, but this you get macular swelling, retinal edema. Okay. You also get choroidal folds. I don't know if you're able to appreciate these linear folds that you get sometimes with patients with a posterior scleritis. So what are the features of posterior scleritis? As I said, you get macular folds or retinal choroidal folds. You get retinal edema and disc edema. So those are the main signs of a posterior scleritis. And we do a B scan ultrasound, which shows you retinal thickening. And you can also see, if you compare the two eyes, you can see posterior scleral thickening here with proptosis. And the treatment of immune-related scleritis is just like for any autoimmune disease. Basically, you more than likely, well, we start off with topical steroids, may relieve symptoms, but often does not affect the natural history of the scleral inflammation. Right? We use systemic NSAIDs in non-necrotizing disease. Okay, but once you have necrotizing disease, you're going to have to use systemic steroids usually. And if the systemic steroids fail, then we use cytotoxic agents. And this is just a little just to demonstrate the difference between an episcleritis and a scleritis. For the pathophysiology, most cases of episcleritis are idiopathic. However, a third of the cases of episcleritis may be associated with autoimmune diseases. And if a patient presents with a scleritis, you have to investigate. Symptoms: mild pain, redness, irritation, acute onset. Scleritis usually more insidious. Pain is very severe, blurred vision, and you may have vision loss and photophobia. Okay, when they have what we usually do also when we have a patient who we're trying to decide is this a scleritis or episcleritis, we instill phenylephrine eye drops. And generally speaking, with phenylephrine in an episcleritis, the superficial vessels are blanched, so the eye looks white. But if it's a scleritis, there's no blanching. Okay? And of course, treatment, as I said, for episcleritis, usually it's a self-limiting condition, and if they're having discomfort, you may give them topical steroids. If you suspect a patient has scleritis, they need to be referred to the ophthalmologist, because they will most often, quite likely, they may require systemic immunosuppression. All right, so you can go through that again. And just another chart again, okay, comparing episcleritis to a scleritis. All right, so we're running out of time. What time is it? It's 11 o'clock. Okay, I have half an hour. We still have other things to get to. True or false? Complications of scleritis include, can you get a cataract with a scleritis? Anybody? No, nobody knows.
False.
Usually, if you get a scleritis, cataracts, it wouldn't necessarily be due to the scleritis itself. Usually, what happens if you treat them with steroids, a complication of the steroid, as opposed to a complication of the scleritis itself. Okay, so I would put false, yes. Can you get a hypotony? Soft eye?
No, it's not,
False.
no.
No, you can get a hypotony, yes.
Oh.
Do you get scleral melt and perforation?
True.
True.
Can you get astigmatism?
True.
True.
Yes, you can, because remember now the scleral, you can get distortion leading to distortion of the cornea. Okay? So they do get astigmatism. Glaucoma is the commonest cause of visual loss. Is it?
False.
I would say false.
False.
Episcleritis is a common cause of a red eye in the elderly. Is it? In the elderly?
False.
It's usually young people, isn't it? False. It's a self-limiting condition of young adults.
True.
True. It's associated with excess conjunctival discharge.
True.
Episcleritis? Conjunctival discharge?
No.
It's false.
That's absolutely false.
Response to local antibiotics.
False.
False. It's not an infective condition, it's an inflammatory condition.
Mm-hmm.
Inflammation of the sclera. Means these are easy questions.
Yeah. True.
Does episcleritis mean inflammation of the sclera?
Yeah. True.
Oh. Episcleritis means inflammation of the episclera.
Yeah. Episclera.
So that's false, right? Yeah. Okay. True or false regarding scleritis? All patients with rheumatoid arthritis have scleritis at some time in their lives. That's false. It's not as high as that. It's about, I think, 6%, less than 10%. 20 to 30% of all cases are associated with rheumatoid arthritis. True, right. 75% of cases in rheumatoid-related scleritis are bilateral.
True.
It's true. Or it might even be more than that. Scleral necrosis without inflammation is what it says leads to scleral malacia perforans. Is that correct?
Correct.
Correct. The following may be seen in posterior psoriasis: a raised IOP.
False.
You actually can get a raised intraocular pressure.
Okay.
A white eye.
True.
Is true. But in most cases, remember now, 80% of cases you have an accompanying anterior scleritis, but not everybody has an anterior scleritis. So the eye may actually look, does not necessarily have to look inflamed. So you may have a white eye in patients with posterior scleritis. So that is true. Do you get a proptosis?
True.
True. Do you get facial nerve palsy?
False.
No.
False.
Red herring, no association. Do you get disc edema? Can you
True.
True. Can you get an exudative retinal detachment?
Yes.
True.
True. Okay. Scleritis may be associated with rheumatoid arthritis.
True.
True. Right. So it accounts for 30%, the rheumatoid, 30% of cases of scleritis. Juvenile chronic arthritis.
True.
True.
SLE.
True.
Herpes zoster. Not sure. It is true. Herpes zoster is a cause of a scleritis, right? So remember now, you have other causes of scleritis apart from autoimmune diseases, okay? can be secondary to viral infections like herpes zoster. I don't know if we need to go through, because I think you need to do some reading before we do this one. Ocular manifestations of Wegener's, a severe steatitis, which may be the only manifestation of the disease. Is that true? It's true. Can you get a optic disc?
True.
True, because it can cause a scleritis, yes. Do you get anterior ischemic optic neuropathy? I'll answer that for you. That's false. Women are more commonly affected than men. Is that true or false?
True.
It's actually false. So these are one of the few immune diseases where men are more commonly affected than women. All right, Wegener's. High dose prednisone and cyclophosphamide is a treatment of choice. It's true. Sjogren syndrome, 4 times more common in women than in men. True or false?
True.
True.
It's actually even more than that. It's
Or
about 9 times. It's 9 times. Okay?
9 times.
Affects 50% of patients with rheumatoid arthritis. Is characterized by lymphocytic infiltration of the exocrine gland. Is it?
False?
False. When secondary to an autoimmune disorder causes carotid or other major salivary gland enlargement in 66% of cases. It's true. Okay, it's associated with a normal C-reactive protein. Is that true? Do you think that could be true?
Oh,
False,
False.
because usually the C-reactive protein is usually elevated in most of these cases, isn't it? Yes. I think you guys have some reading to do. All right, case scenario. Let's move on. What is this I'm doing here? Okay, so I'm not going to spend a lot of time. This was the next set of slides really are about uveitis, but you have a whole uveitis session. So I'm not really going to spend a lot of time on uveitis, but just to say that uveitis is seen in certain autoimmune diseases, right? So you have a case scenario of a 46-year-old female presenting with a history of a painful red eye, pain worse in bright light, so the patient has photophobia and blurred vision. All right? They have a past of family history. They give a history of recurrent episodes of a red eye in the past. And in the review of systems, they complain they have some joint pains. When the visual acuity of which eye is this is the right eye, they have some blurring of the vision in the right eye, and the intraocular pressure in the right eye is lower than in the left. The intraocular pressure in the right eye is 10, and it's 18 in the left. Let's go to the next slide. Oh, I think I missed out something. I should have had a picture here. Sorry, guys. So, just from the history, what do you think this patient has, right? They have painful red eye, photophobia, blurred vision. Visual acuity is down with lower intraocular pressure. And they have some history of joint pains, perhaps. So the differential of a painful red eye, we have to go through again and think about iritis, pruritus, episcleritis, and other things. Well, the patient is mainly complaining of photophobia. So my first differential would be an iritis, actually, an anterior uveitis. Okay? But let's move on, because I think I seem to have inadvertently removed the slide showing you that picture. So this is a 32-year-old male with Crohn's disease. Miss Chantel, you're asking a question. Would you like to describe what you're seeing? In the first photograph to your left. What do you think is happening here? What are the signs? 32-year-old male with Crohn's disease, presenting with a red eye, painful red eye, and photophobia. Do you have any idea? Obviously, what do you think is happening? All right, let's try this photograph. You see my pointer?
Yes, doc.
Yeah.
Yes,
What
doc.
do you think? How would you describe this pupil? What do you think is happening to the pupil here?
It looks like there's a bit of ulceration almost.
Mm-hmm.
There seems to be a bit of ulceration almost, or some sort of
Okay, no, there's no operation. So this is a pupil margin. Is the pupil irregular or is it regular?
it's irregular.
All right, it's slightly irregular, and you're seeing like the sort of white areas here, right?
Yes, sir.
Okay. So what is happening here is that you're having adhesions between the iris at the pupillar margin. Right. Thank you, Mr. Ramprasad. This is what we call posterior synecdoche. Okay, and it's a sign that you get in patients with inflammation of the iris and the anterior segment, right? With iritis, so you get adhesions between the iris and the anterior lens capsule, and that's called posterior synecdoche. And in this patient, what you're seeing are some deposits on the lens of the eye. Okay. So what is your diagnosis, Mr. Ramprasad? What is it having?
An anterior chamber uveitis.
An anterior
Anterior,
uveitis.
anterior
All right,
uveitis.
also called an iritis. Okay. Why is the patient photophobic? Anybody has any ideas of why patients with iritis are photophobic?
I'm guessing here, but most likely the eye itself inside the eye doesn't really have pain receptors, so the photoreceptors are irritated, and that's what gives them that irritation.
No, actually, that's not why. Miss Gordon, any ideas? I see you put your hand up.
No, it's because Doctor, I'm kind of lost from the whole posterior synecdoche point. I
Okay. You're not
right.
understanding, you're not getting that point?
No, I'm not really.
Okay, so when you
Kind
have
of lost me from that point.
okay, when you have inflammation in the
Is
eye,
it
right?
because of
So in an iritis, it's an inflammatory condition. So you have inflammatory cells, okay, in the anterior chamber of the eye. And what happens when you have inflammation in the eye? You get adhesions. So the pupil margin becomes adherent to the anterior lens capsule, to the lens in the eye. And then you get the pupil margin becomes irregular. So these areas here, right, are where you are having adhesions between at the pupil margin and the anterior lens capsule, the capsule of the lens. And that's what we call posterior synecdoche. Is that helping you at all?
It helps a bit more, yes. Okay.
Okay.
Thank you.
Why is the patient photophobic? Anybody has to know doesn't anybody know why the patient with iritis has photophobia? Well, usually when they have an iritis, inflammation of the anterior segment, inflammation of the iris and the ciliary body, you get ciliary spasm. So the patient goes into ciliary spasm, and that is what causes the pain with light. All right, what are the signs of anterior uveitis? Anybody knows? Do you get ciliary injection? Is that true or false? Ever heard of the term ciliary injection?
True.
It's true, right? So you get the eye is red, but there's a particular increased redness right around the cornea. What we also call it circumcorneal injection. Okay, so you get ciliary injection because that is the site of the ciliary body. Cells in the anterior chamber, is that true? You get inflammatory cells in the anterior chamber? True or false? True.
True.
That's true. So we get aqueous flare. Is that true or false?
True.
True. Can you get macular edema? Remember now this is anterior uveitis. Would you get macular edema in an anterior uveitis?
False.
False. Do you get keratic precipitates?
True.
True. And you know that you get posterior synechiae. Yes, you get posterior synechiae. That's true, isn't it? Can you get meiosis? Yes. Remember, now you can get posterior synechiae. So sometimes the pupil actually becomes myotic because the pupil becomes adherent, small and adherent. Okay? So that is true. So as I said, I'm not really going to spend too much time on this because you have an entire lecture on that. All right. So, but systemic autoimmune conditions, which, right, you have in particular, you have to think of your inflammatory bowel disease, juvenile rheumatoid arthritis, and it's mainly associated with your HLA-B27 associated spondyloarthropathies. And these are not, that's not an autoimmune condition, but systemic conditions associated with uveitis, right? Mainly uritis, ankylosing spondylitis, psoriatic arthropathy. Okay, and I'm going to skip that. You're going to have a whole lecture on uveitis. Just for a quick, some MCQs, so you will get MCQs on uveitis, so you're going to have to make sure you can read upon your uveitis, especially your anterior uveitis, iritis. True or false? Iridocyclitis is synonymous with a posterior uveitis. Is that true or false? Melanie? Traboulet? Is iridocyclitis synonymous with a posterior uveitis? False. Iridocyclitis is synonymous with what kind of uveitis?
Anterior.
Yes. Iritis does not occur without choroiditis. That's false. Is an inflammation is uveitis an inflammation of the retina? Is uveitis an inflammation of the retina? True or false?
False.
False. It's inflammation of the uveal tissue, isn't it? It's usually painless. Is uveitis usually painless?
False.
False. Is uveitis a feature of thyroid eye disease? I don't know if you have you had your thyroid eye disease lecture yet?
Yeah, we did thyroid IDs.
Yes.
So is uveitis a feature of our thyroid eye disease? I think it's false. It's usually due to staphylococcus infection. Come on, guys, wake up, wake up, wake up.
False.
It is
False.
usually due to false, right?
Oh,
The symptoms of posterior uveitis that occur commonly are blurred vision,
True.
true.
floaters,
True.
True.
a painful red eye.
False.
True.
I
True.
don't think so. False.
False.
Posterior uveitis now. Diplopia, do they have double vision?
False.
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 Do they have epiphoro? False. Remember, this
False.
is posterior uveitis, not anterior. Alright. So this is basically a table demonstrate just giving you a little idea of the different ocular manifestations of autoimmune disease, and you can go through all of that. The main diseases which cause eye problems, of course, are rheumatoid arthritis and SLE, but the others are associated. Okay, so rheumatoid, as we know, as I said before, they get a dry eye syndrome, keratoconjunctivitis, sickle scleritis, keratitis, you name it, rheumatoid arthritis can cause it. Retinal vasculitis, you can get an exudative retinal detachment, macular edema, and SLE likewise. Okay, but other autoimmune diseases implicated are juvenile rheumatoid arthritis, secondary Sjogren syndrome, Reiter's syndrome, inflammatory bowel disease, ankylosing spondylitis. Okay. I was going to talk about thyroid eye disease, but did you have your lecture on that already? This is considered a autoimmune disease that affects the eye. Did you have your thyroid eye disease lecture?
Yes.
Yes. So I don't need to. This is a 32-year-old female with thyroid ophthalmopathy. What are the lead signs in thyroid eye disease? We should be able to go through this very quickly.
They have eyelid retraction.
Correct. And
You have a scleral showing.
Carol, oh, very good. Okay, so and do you know any non-thyroid causes of lid retraction by anybody?
Graves.
No, nobody. Ever heard of like paranoid?
Possibly would be one. Being it and primarily autoimmune disorder. That would
I
be
didn't hear. Can you repeat that?
I was wondering if Graves would be considered because it's primarily autoimmune and resulting in hypothyroidism or hypomagnesemia.
Yes, Graves' disease. Yes, The other causes, do you know any other causes of lid retraction apart from Graves' disease?
Could a stroke cause that, Doc?
I can't hear you.
Sorry?
Not hearing you.
Oh, I'm asking if a stroke can cause that.
I think you need to write it in the chat because for some reason you're not clear to me.
Trauma could cause it.
Stroke. A stroke where? So have you done anything like Parinaud's phenomenon? You ever heard of Parinaud's disease?
Repeat. Can you please say?
Parinaud's, Parinauds. Never heard of that. Okay. All right. I think that will be for another lecture. So basically, you do know the features of thyroid eye disease, right? So you get fusiform enlargement of your extraocular muscles and sparing of the tendons, right? Everybody knows that. So I think I'm going to not dwell too much on this. We can just answer a few MCQs since we had the lecture already. Miss Chantal, why would you want to stain the cornea for a patient with thyroid eye disease? Anybody? What would we be looking for?
Abrasions. Would you be looking for
This abrasion because it might not be able to go from
Well, so what happens in thyroid eye disease? Remember now you have lid retraction and you have sterile
Yeah.
flow and proptosis. So what happens to the cornea in thyroid eye disease?
It's
You get exposed, right? You get something called exposure keratopathy. So why would we stain? What are we staining for in that case?
Would you be looking for any abrasions?
Correct, you're looking for corneal abrasions, yes. Or you can even be looking for a dry eye, so you're looking for any punctate staining, corneal abrasions, because the cornea is exposed, so you get something called corneal, you get exposure keratopathy. And it can even, I've seen it lead to perforation, and you get chemosis, as you know, okay? Lid retraction and proptosis. And let me see. And of course, do you all know what are the three main complications of thyroid eye disease? So you can get exposure keratopathy, you can get an optic neuropathy, right? And you get an optic neuropathy because you have compression of the optic nerve, usually at the orbital apex. And the patient presents with decreased visual acuity, an RAPD, color desaturation, and visual field effects, okay? Quite often, however, the optic disc can appear normal, but may be swollen or atrophic. All right, so optic neuropathy occurs in up to 60% of cases, and you quite often get an early defective color vision, but usually the optic disc may appear normal in the early stages. And the other complication you get with thyroid eye disease is a restrictive myopathy. So 30 to 50% of patients with a thyroid eye disease develop ophthalmoplegia. And the ocular motility problem is usually due to restriction initially from inflammatory edema, but later they develop fibrosis of the recti muscles. And of course, you know, the most common defect is elevation. So who else can I ask here? Let me see. So Miss Husani Hogg? Husani Hogg?
Good morning.
Good morning. So in an elevation defect, which ocular muscle, extraocular muscle you think is fibrosed? Is it the superior inferior rectus, medial or lateral? Which one is affected when you can't elevate the eye?
The superior rectus?
No. Anybody else? So it would be the inferior rectus. Remember now it's a restrictive myopathy, right? So what happens is that the inferior rectus becomes fibrotic, and so the patient is unable to elevate the eye. Okay? So remember now it's a restrictive myopathy. So in an elevation defect, it will be the inferior rectus that would be affected. And in abduction, it would be which muscle is affected? Anybody?
medial rectus.
Medial, doc?
That's correct. Medial rectus. So the medial rectus would be the muscle that is fibrotic, and preventing the patient from abducting the eye. And when they're looking down, then obviously it would be the superior rectus. And when you are adducting, it would be the, what would be would have to be fibrosed to prevent the patient looking medially. It would be the lateral rectus, wouldn't it? Yes. Okay. Treatment, and I think you must have gone through all the treatment, but usually it's self-limiting. But of course, you may have to intervene. So therapy is usually directed towards decreasing orbital congestion and inflammation, or expanding the bony volume. All right. So, as always, how do we decrease inflammation? We give systemic corticosteroids. All right. Other things that we do, of course, as I mentioned before, they have exposure. So you have to lubricate the eye. They have to get topical artificial tears. And if they don't respond to systemic steroids, then we do orbital decompression, which is usually reserved for very severe cases of proptosis with exposure, or if the patient is having compression of their optic nerve. So if they're having a compressive optic neuropathy or a severe proptosis with exposure keratopathy, we may have to actually do surgery. And orbital radiotherapy can be used. Okay, and what do we do in orbital decompression? You know that we can remove the orbital floor or the medial wall of the orbit. Okay, and just to show you before and after pictures, patient who had really horrible looking proptosis and lid retraction, post decompression looks a lot better cosmetically. And similar here, proptosed eyes before and after orbital decompression. Okay, true or false? I think we're coming to, oh my God, are we coming to the end? Thyroid eye disease may be exacerbated by smoking. True or false?
True.
True. Who does it affect more, males or females?
Females.
Female.
Okay. Radioiodine treatment, it can be exacerbated by radioiodine treatment of hyperthyroidism. It's actually true. All right. It is well documented that patients who receive radioiodine treatment sometimes get worsening of their proptosis and their thyroid eye disease. Okay. Can it be exacerbated by diabetes? I think that's false. So yeah, thyroid eye disease, ocular motility is restricted by fibrotic contracture in the active phase. Is that true or false?
False.
That's false. So you don't get fibrotic contracture in the active phase. When do you get fibrotic contracture?
Chronic phase. Passive phase.
In the chronic, right, quiescent phase, correct. What else is there? Sorry, oh my goodness. I think, are you still seeing my slides?
No.
No, no.
Oh, I just managed to take out my thing. Sorry about that. Defective elevation is caused by a fibrotic inferior rectus. Is that true or false?
True.
It's true, right?
Sorry.
Who just explained? Yes. Does not occur in Hashimoto's thyroiditis. Is that true?
False.
It's false. Thyroiditis is not a feature of thyroid cancer. True or false?
False.
That's
True.
true. It's not a feature of thyroid cancer. Congestive phase tends to remit within 3 years.
True. 3 to 5.
True. Exposure keratopathy and optic neuropathy are indications for orbital decompression.
True.
It's true, right? Yes, those are the two main causes. Severe exposure keratopathy with proptosis and optic neuropathy. All right? Do you want me to continue with the MCQs or should we move? I have one last topic to go through with you guys. And we're like over our time now. No answer. Okay. Let me go to.
Sorry, Doc. Read the thyroid cancer question. Is it that thyroid eye disease is never associated with thyroid cancer? Because that's what I got from it.
It's not a feature. I didn't say it's never. But thyroid eye disease is not something that we associate with thyroid cancer. No. Remember now, thyroid eye disease, we're talking about inflammatory autoimmune disease, Graves' disease. That's not a feature of thyroid cancer.
Okay.
It's not a frequent association or a normal association.
Okay. Thank you.
Okay? Mm-hmm. Okay, so I was asking you other causes of lid retraction. So just here, this is a quick question on it. So non-thyroid causes of lid retraction include aberrant degeneration of the third nerve. Is that true? It's true. Paranoid syndrome.
True.
True. Surgical overcorrection in ptosis surgery.
True.
Iatrogenic. True. Cirrhosis of the liver.
False.
False.
No, it's true. You don't remember from your medicine about the causes of one of the features of cirrhosis, lid retraction. But cirrhosis of the liver and uremia are both causes of lid retraction. Okay? All right, let me just go on to the final case scenario. A young female presenting with a history of drooping eyelids, which gets worse as the day progresses, and sometimes complaining of double vision. Who would like to? Anybody who would like to volunteer to describe what they're seeing here? What's the clinical sign in this photograph? Anybody? Chantel?
Yes, Doc?
What are you seeing here? This photograph.
I see a young female with bilateral ptosis, it seems.
Okay, bilateral ptosis. So very good. The patient has droopy lids and double vision. What diagnosis are you thinking of?
It could be many things. It could be damage to her nerve. It could be a neuromuscular problem like myasthenia.
Yeah, myasthenia, yes. A neuromuscular problem like myasthenia, yes. Let's see if we can get any further here. All right, so myasthenia gravis, autoimmune disease, where you have damage against the ACH receptors in striated muscle. It affects females twice as commonly as males, and it may be ocular, bulbar, or generalized, okay? And why is this thing doing this? Next slide. Okay, I think it's a sign that I'm supposed to end this lecture. It's just not going forward.
Excuse me, Doc, we're not seeing the slide now.
I realize that. I don't know what's happening with this presentation. I'm trying to get it back up for you. Okay, here we go. Okay. Right, so in ptosis, usually the ptosis is usually bilateral insidious. It's bilateral, but frequently asymmetrical, okay? Worse at the end of the day, and it's usually least on awakening, and of course worse on prolonged upgaze due to fatigue. And then you've heard about the Kogan twitch sign, brief upshoot of the eyelid as the eyes move from depression to the primary position. And you've heard of the positive ice test, right? Ice pack test, where there's an improvement in the severity of the ptosis after an ice pack is placed on the eye as the cold improves neuromuscular transmission. Let me go back. Am I finished? And in ocular motility, what happens is that the patients frequently have diplopia, frequently vertical, but maybe any or all of the extraocular muscles may be affected. You can also get nystagmoid movement. Bizarre defects of ocular motility may also occur, so myasthenia should always be considered in any differential diagnosis where you have an ocular motility disorder. Okay? And of course, you know the tests, the hydrophonium test or tensilon, all right? You also would do your serum acetylcholine receptor antibody levels present in approximately 90% of cases. And you do a thoracic CT or MRI to detect a thymoma, which is present in approximately 10% of cases. And you know your treatment options, your long-acting anticholinerasterases, pyridostigmine, neostigmine, okay? Steroids, immunosuppressants, plasma exchange, IV immunoglobulin thymectomy. Patients with pure ocular myasthenia, however, are usually not helped by thymectomy. Okay, so a 56-year-old patient with myasthenia gravis presented with bilateral ptosis and intermittent double vision. So you should read up about it, and you must know about the main clinical types of myasthenia. Okay, ocular, bulbar, or generalized. What investigations that you need to do are appropriate in suspected cases, and you can list some other causes of ptosis. Okay. In myasthenia, the eyes alone may be involved. Is that true or false?
False.
No, you can get ocular myasthenia, can't you? Right? So the eyes may alone may be involved. So that must be true.
Oh, okay. I
Mm?
thought you were saying it's limited to the eyes.
No, the eyes alone may be involved.
True.
Intermittent vertical squint may occur. That's true. Ptosis may be the only sign. No, that the word, the term could be as a misleading, but ptosis may be the only sign. That is true. The condition is a cause of cataract. Is that true? Ocular myasthenia. That's false.
False.
Symptoms may be relieved by the use of neostigmine or pyridostigmine. You know that is true. Anti-acetylcholine antibodies are elevated in 60% of patients with ocular myasthenia. True or false?
True. If not more.
It could be more. Is it 90% or this is ocular myasthenia? So 60% might be right. Thymoma is present in 10% of patients. True.
True.
Nystagmus is a recognized feature.
False.
False.
Remember, I said you can get nystagmus in or nystagmoid movements in extreme of gazes. So that's true. Okay. It didn't say a frequent feature. It says a
Excuse
recognized feature. Okay.
excuse me. Excuse me, Doc. Can you explain the difference between nystagmus and nystagmoid?
Okay. So basically, nystagmus is a pendular motion of the eyes, right? Movement. So at extreme of this, you can get these nystagmus. It's not strictly speaking nystagmus. It's only seen at the extremes of this. So this could be a disputed question. You know, I suppose you could say nystagmus. You could say that it's false. Okay.
Okay, thank you.
Right, so you can get some pendular movements at the extremes of gaze, which we would call, we characterize or we describe sometimes as nystagmoid, where you get some sort of seesaw motion. Also, antibodies are directed against presynaptic membrane of the neuromuscular junction. Is that true or false?
False.
False.
False. It's not presynaptic, is it? It is what?
False.
Post-synaptic.
Postsynaptic, right.
False.
Ocular muscles are affected at some stage of the disorder in over 90% of cases. I think that's true. Okay?
True.
Yes, it's true. All right, so that's the end of it. I think we went on a bit too long. I think I'm going to have to adjust this lecture. Any questions at all? I think most people have tuned out by this. Are there any questions you'd like to ask?
No, Doc.
So autoimmune, there are many autoimmune conditions that affect the eye, okay? The main ones we talked about before was, of course, your rheumatoid arthritis, lupus, and those are the main ones which cause dry eye syndrome, steritis, episcleritis, uveitis. But there are other autoimmune diseases which also have ocular manifestations, such as myasthenia gravis and Graves' disease. Okay, so that's it for today. So you're coming near to the end of your ophthalmology rotation. I believe next week I have 2 tutorials with you. One on the painless red eye and ocular trauma. Okay, so I'll see you next week. Next week, Monday and Friday, I believe. Or is it the following week? Could be the following week. Okay, so have a good day. You can get some rest now. Rest your eyes. All your eyes are dry. My eyes are dry now.
Doc, I have a question. For the tutorial, is it that we're going over the topic or we're presenting the topic to you?
I think you present the topics to me.
Okay, because we haven't gotten that list as yet, and I wasn't sure what the tutorials meant.
Haven't given you that list as yet?
No,
No,
so I
no.
was wondering
Oh, yeah, I'm
what is that?
surprised. All right, so it's not next week. No, the tutorials aren't next week. The tutorials are the following week. So oh yes, I'm doing on the 29th, this Tuesday, painless loss of vision. Okay, so I'll see you on Tuesday, painless loss of vision. Yeah. All right, I'm not quite sure. I'll drop Dr. Swaby a note to ask him, since you said you haven't received your topics as yet. But
Okay,
you'll be
thank you.
okay. All right then. Enjoy the rest of your day.
Thank you, Doc. Thank you.
Thank you.